Everyone, this is part 5 of a 6-week series. We are so glad that you are here, and I will now turn it over to Dr. Corso and let him talk to us about part 5.
Great, thanks, Kim. So once again, this is PROSPER, the proactive reduction of suicide in populations via evidence-based research. This is 5 of 6 modules. I'm going to start with a quick review. So here, as usual, here's our bibliography, our references here, our learning objectives. We learned about the suicidal mode. Again, this is what's happening when someone is experiencing suicidal thoughts and feelings. They may even be engaging in the suicidal behaviors, and there is certainly a certain type of physiology that goes along with this. The reason we point this out is to make sure that we're not using words like active suicide, passive suicide. Those aren't really as helpful clinically, but rather to say the person's suicidal mode has turned on, or it was turned on earlier this week. It is not on right now. Most definitely the suicidal mode turns on typically after a trigger, and we all have predispositions to suicide, but these factors here, while relevant to the nature of how suicide occurs, we don't want to use predispositions and triggers as some sort of predictors or risk factors to consider. Rather, we want to better understand what's happening within the person's suicidal mode. We want to take a collaborative approach, just as a refresher, which means we have to take a bit of a risk that what the patient tells us about his or her suicidal symptoms is exactly what he or she is feeling. It is sort of, I don't want to say bona fide, but it is legitimate. Part of that collaborative approach involves empowering patients, which means trying to do our best to equip them with whatever resources they might need to manage their own symptoms. So risk assessment, historically, we tend to see it as a sort of moment where our license might be at stake, where we might be responsible for this patient. And with suicidal patients, we want to work against that mentality. In fact, we want to try to instead put the patient in the driver's seat and have us be the navigator, so to speak, which means respecting his or her autonomy to kill themselves, not moralizing, avoiding power struggles, power differentials. And if those do come up and it feels like a bit of friction, to call attention to it and say, hey, it seems like this has gotten to be a little more tense than when you first came in here, and I'm wondering what that's about. Is there something you're concerned about? It's perfectly natural for that kind of tension to happen. Sometimes it happens because the person has had experience in the system and frankly has not had a good run of the system, let's say being hospitalized, sometimes being involuntarily hospitalized. And there are other times where what happens is the patient by nature wants relief, but also wants privacy. And the provider by nature wants to preserve his or her license, but also wants to help the patient. Above all, we don't want to talk the person out of killing themselves. And this involves anything from talking them off the ledge to suggesting, well, what would happen if you killed yourself? What would the people around you think? Or how would that affect your children or your family, right? So really trying to do our best not to talk them out of it. And if you haven't, I think I've reminded everyone of this each time or nudged you to think about it. But if you haven't considered, what does it sound like when I'm talking someone out of it? If you're not aware of what that sounds like, really important to check in with yourself and figure out, okay, what does that sound like? Do I say, well, maybe you should just try this, or wow, you have so much to live for? Whatever that is, it tends to alienate patients and not make it easier. Okay. And of course, we want to not only do risk assessment, but rather help people develop effective coping skills. According to the research, that comes down to two main types of coping skills: emotional regulation skills, which has some subcomponents, and then adopting more helpful ways of thinking, right? So the thinking style that says, oh, everyone would be better off dead if I were gone. Those are not true. Generally, that people are not better off dead when someone ends their life or kills themselves. So helping the person manage the suicidal mode when it pops up, but then over time, more longer term, helping them rebuild healthier, more adaptive ways of thinking. Last week, we went over a risk assessment, our 5 skills. We're going to go over 4 of them today, just reviewing, and then we'll do a quick demonstration in which I will probably pull up this very slide, and I will ask for a participant, and you can pretend to be the patient, and I'll just do a quick risk assessment. Part of the purpose here is to demonstrate that not only is it a straightforward, logical, triage-based, methodical approach, but that it doesn't have to take an hour. And so, in fact, we'll probably try to do it in about 10 minutes. And then we'll break up into groups, and everybody will get a chance to pair up with someone and practice this skill. This sounds a bit hokey, but I can't express and emphasize this more. If you're not used to asking questions this way, if you don't practice during this webinar, I have zero confidence you'll change your lexicon, your style, your approach in person. And not because I don't have faith in each and every one of you, but just because it's human nature. Okay, so when we're fighting against years and years of practicing one way, and then we try to spend about a half hour practicing another, it's really hard for a half an hour of practice to compete with an entire lifetime of practice. But we're going to give it a try, and a half an hour is certainly better than nothing. So skill 1, if you remember, is differentiating SI from DI. That's suicidal ideation versus death ideation. Skill number 2, that is assessing for multiple attempts in the past. And again, 2 or more are the important ones that suggest chronic moderate risk. Suicidal behaviors are also, past suicidal behaviors are also what we are looking for. Now, some people get a little bit mixed up here and they say, oh, have you had suicidal thoughts in the past? Don't bother asking that question. There's no juice for the squeeze. It doesn't give you better predictability, doesn't give you a higher indication of risk, but a history of behaviors does give you an indication of what might come. So again, just the less is more with regard to managing suicidal patients, and that sounds counterintuitive, but especially at the risk assessment, less is more. We have decades and decades of beliefs about what we have to do and how much time we have to spend in contemporary suicidology. The recent research, it doesn't hold up. The third skill is assessing the current suicidal episode. So that has 4 steps to it. Thoughts and desires. And remember, for all of these, just like any other problem in primary care, we'd want to ask, what's the frequency, the duration, the intensity of the symptoms? Plans, preparation, rehearsal, these are more behavioral, right? When we plan something, when we rehearse something, when we prepare for something, let's say I'm preparing to go to Ireland on vacation. If I'm thinking about what clothes I'm going to put in my suitcase, if I'm even taking those clothes out, I'm much closer to actually executing that action. And so similarly, if someone's thinking about which firearm should I use, what day of the week could I do it, what would happen if someone caught me, which method do I want to use? That kind of preparation, rehearsal, planning, it brings someone closer to actually acting on it. And so that's why plans, prep, and rehearsal are weighted as heavier risks than thoughts and desires. Now, remember, going back to what we said way back in the first module, our risk assessment historically has come down to this checklist of 60 some odd things, and that's not really accurate. We have recent studies showing that our ability to predict future suicides is essentially 0. And so when we think about risk assessment, what we should be thinking about in order to be the most accurate and constructive is to consider, what do I need to do with this person in front of me? What level of service does he, she, they need? And if the person needs 24/7 supervision, eyes on, then they need to go to the hospital. If the person, because the hospitals, again, they just ensure safety, they remove the opportunity to attempt They do not treat the suicidal symptoms, the feelings, the thoughts, which is why 1 out of 4 people within 7 days of discharge die by suicide. And so instead, our risk assessment mindset should really be, okay, does this person need primary care treatment as usual, or maybe enhanced primary care if we have behavioral health integrated? Do they need outpatient mental health? Do they need some sort of a partial hospitalization or intensive outpatient program, or do they need psychiatric hospitalization? So really, we're looking at 4 main dispositions, and to be honest, these 3 are somewhat the same. The 4th, hospitalizing them, is really the only one that's a bit different, because the other 3 actually involve treatment, not just supervision and ensuring the person doesn't kill themselves. So just a reminder on that, old habits die hard, and I like to sort of hit that home each time. The 3rd step here is not asking about intent, because that's not really fair, but understanding intent by looking at it through the context of ambivalence. Remember that suicide is a state of ambivalence. People have reasons for living, reasons for dying. So to say, do you intend to die, is not really a fair question. The answer from every patient would be, yes, I intend to die and I intend to live. So intent alone is sort of an antiquated approach to helping to understand risk. Access to lethal means, this is typically asking them if they have a firearm at home or if someone in the house has a firearm. Again, you can do this at the very end after skill number 5, which is the crisis response plan. That's when I like to do it, but you can also do it at this juncture to better understand the risk and the imminence. Skill number 4 is to talk about reasons for living. It's exceedingly difficult to talk about reasons for living unless we first talk about ambivalence. So here's a good quote on the screen of how I encourage you to use it as a script. If you say it verbatim a dozen or so times, you'll adopt your own language and it'll feel comfortable over time. But strongly encourage you to get to that ambivalence, because that's how we start pivoting from assessment to intervention. So toward the end of the risk assessment, we're asking about ambivalence. We might ask them, what's the most important thing in life to you right now? What would you be doing if these things weren't dragging you down? And all of those sort of intermediary questions on this slide are getting at, why does this patient, what do they have to live for, right? So again, looking at suicide as a state of ambivalence, reasons for living, reasons for dying. And the pivot point to move from risk assessment to intervention is really identifying those reasons for living. Incidentally, that's also what typically shuts down that suicidal mode. And so if the patient's in your office and his or her suicidal mode is turned on, our job is to turn it off. Okay, questions about where we've been. Notice that the refresher gets longer and longer the more we get towards session 6 or module 6, because we have more content to cover. Any questions about where we've been? Okay, hearing none, what I would ask is for a volunteer who is willing to pretend to be a patient. I would ask you to be a garden variety patient, certainly not the most difficult, because then you'll just see my motivational interviewing skills instead of the suicide risk assessment skills. What I'm going to do is take about 10 to 15 minutes and do a quick risk assessment. Let me go back to this so that you have the schematic and you can sort of follow along. When I send out the slides today, I will also send this handout, although I believe this handout may have been distributed in advance, right before webinar 1. So who is willing to be a patient? And if that is Caitlin or Jenny or Kim, that works fine with me. That way everyone else who's a learner can just sort of soak it up. But I won't determine who's the volunteer, I'll just ask.
Sure, I'll do it.
Thanks so much, Jenny. So Jenny is going to be a 28-year-old single female professional. Does that work for you, Jenny?
Yes.
Awesome. Okay, 28-year-old single female professional. Well, so it's all part of the exercise. Put yourself in that mindset. You'll feel 28, right? 1 or 2 years ago. And then, so you're a professional. You've come in for depression, and your PCP said, well, would love to, you said, you talked about depression with your primary care provider, and your provider said, well, I have behavioral health in-house here. Would you be willing to talk to them? And you said, yes. The PCP asked you if you were thinking of killing yourself, and you said, yes, I've had those thoughts in the past. So the PCP said, hey, Dr. Corso, Kent, would you come on and see Jenny for us? Okay, so we're working in primary care. I'm a psychologist working in primary care, right in the exam room right next door to your doc. And so your doc walks you into me. All right, who's going to be our, Kim, can you be our timekeeper? And when we hit 15 minutes, make us stop.
Sure.
Shut us down. Okay, so hey Jenny, good to meet you. Thanks for walking in today. It sounds like you do have some time to chat real quick about what's going on.
Yeah, sure. I don't have to be anywhere.
Okay, so Dr. Jones said that you had spoken to her about some depression and also mentioned that you had previously had some thoughts of ending your life. Is that what you wanted to talk about today?
Well, I wasn't necessarily expecting to talk, but yes.
Okay, but is this something you'd be willing to accept our help with or discuss a little further to see how we can help?
Yeah, sure.
Okay, so when's the last time you had thoughts of killing yourself or ending your life?
I guess yesterday, maybe.
Okay, and so what time of day, when did it happen yesterday, Jenny?
When I was laying down to go to sleep, my mind was just racing.
Okay, last night. Okay, and then over the last 30 days, is this the only time this has happened or has this happened a bit more?
No, it's been happening pretty much every day.
Okay.
Just kind of there in the back of my mind.
Okay, so once a day, 5 times a day? How many times each day?
It'd be hard to count. I mean, maybe 5 or 6 times a day.
Okay, and each time it happens, does it last like 1 or 2 seconds? Is it a quick fleeting thought, or is it something where you're sitting for hours thinking about?
It's usually fleeting. I mean, I don't have a whole lot of time to think about things, and
Okay, okay.
but it's bothered me.
Oh, sure, sure. No, they're really unpleasant thoughts. Who wants to keep thinking them, right?
Right.
So, and are the thoughts sort of like, I wish I were dead, or is it sort of like, I wish I were dead and I can see myself making that happen? Is it more like the first or more like the second? Because
I think it's more like the first.
Okay, it's more like the first, because some
Don't want to
people,
be here.
okay, so just not want to be here. But there's never a part of you in the last month that has thought, I don't want to be here and maybe I'll do something about that. Like maybe I'm the one who would end my life.
The only thing is I get scared that I could do something impulsive.
Okay, okay. Have you done something impulsive in the past, like maybe cut yourself or burned yourself or branded yourself or done something that was caused injury, but you weren't thinking of killing yourself, you're just, for some other reason, you were harming yourself?
Well, yes, sometimes I have impulsively hit the wall.
Okay, okay, like a slap, like a punch.
Punch.
Okay, okay. So I'm hearing, just check me on this, Jenny. I'm hearing that you have had thoughts of not being here, and thoughts that it'd be better off if you weren't here, maybe that you're better off dead, but I'm not hearing that you see yourself killing yourself. Check me on this. Am I hearing you right?
Right. Yes.
Okay. And then
Not purpose. It would be accidentally.
How tell me more
That
about
makes
that.
sense. I mean, just, running off the side of the road or in front of a bus or something that I couldn't control. It's just these thoughts come and I can't make them go away, and I'm afraid that it's going to happen at the wrong time.
Okay. Okay. All right, so that would be a bit more like suicidal thoughts, but I do hear you loud and clear that they're sort of fears. It's not as if you're sitting there thinking, how am I going to kill myself? But rather that you wish you were dead and you think, wow, I might act impulsively and run my car off the road or something like that.
Right.
Am I with you? Okay. Have you ever had a prior suicide attempt, Jenny?
No.
Okay. So let's talk a little more about what's going on right now. You said last night your suicidal mode turned on. Are you familiar with that term, suicidal mode?
No.
Okay, can you think of this like gears to a car? Or think of this like aisles in the supermarket. You know when you're in the frozen aisle, right? Because it's freezing. You know when you're in the vegetable and fruit aisle because it's really open. You know when your suicidal mode is on because certain feelings and thoughts come to mind. There's a physiology, things happening in your body. Sometimes you do certain behaviors. Are you with me when I say that's your suicidal mode? Does that resonate with you? Can you connect with sort of what that feels like?
Yes. Yeah.
Okay. Is your suicidal mode turned on since last night?
Yeah, I'd say it's probably, just feeling that in my body. It's been about a month. It's been on.
Okay. All right. And what was it that was going on in life when this began?
I lost my job.
Okay. Okay. Yeah. I mean, what would you say if I told you that there are quite a few people who lose their job that end up struggling with the kinds of thoughts and feelings you're struggling with?
Well,
Would you believe me?
yeah, I believe you.
Yeah. Yeah, it's really difficult. So have you ever, when you're thinking about running your car off the road or doing something impulsive, sort of, as you said, losing control, have you thought of anything other than just running your car off the road? And have you thought any more about it, like which road or when, or is that not really the way it's unfolded in your mind?
Not so much specifics. No.
Okay. Other than running your car off the road, are there other ways you've thought, oh goodness, I could impulsively do this?
Really just that and the traffic, because I have to walk to the grocery store every now and then.
Okay. Okay.
I know.
All right. Do you have a firearm at home, Jenny, or does someone in your house have a firearm?
Yes.
Okay. And has that come to mind at all as a way to
No.
Okay. Okay. We might come back to that at the end. Okay. So just to summarize, I'm hearing that you, for the past month since you lost your job, you've had thoughts of death, dying, not being here. You've had some real they happen about 5 to 6 times daily for only a few seconds. They pop up in the back of your mind there. And you've thought sort of vaguely, like I might lose control and I could either take my hands off the wheel and crash my car or perhaps step out into front of traffic. But other than that, there's no preparation, any rehearsal, nothing else you've done to sort of act on those thoughts or fears. Am I following you?
Yes.
Okay.
Breaking character real quick.
Yeah.
Should I be more suicidal?
You're perfect. No, you're perfect. This is great. So Jenny, would it be okay if I shared with you a few things that the medical research that we've learned about suicide from the medical research? Would that be okay?
Sure.
So we know that suicide is a state of ambivalence. And so when I say ambivalence, what I mean is a mix of feelings. People have reasons for living and reasons for dying. Okay. And most people who are suicidal don't only want to die. They just don't want to live with all the stuff that's happening in their life. Does that describe you?
Yes.
In other words, if we could fix the job situation, would you still want to die?
Well, it's not so much. Yes, probably if I felt some hope for the future or any sense of security or maybe.
Okay, so let me restate that because I think I'm understanding you, but I want to make sure. So if you had more hope or felt that there was security in your future, you would not want to die. Am I understanding you? That you would want to live?
Yes.
Okay. And so can we dive one layer deeper into this?
Sure.
All right, so let's talk a little more about the ambivalence. It sounds like you are experiencing ambivalence, reasons for living, reasons for dying. You've mentioned 2 really good reasons for dying. When I say good, I mean they're clear. You've lost your job and that gives you less security. And then because it's been a month, you have less hope, right?
Right.
Any other reasons for dying or things that are making life intolerable or miserable?
I'm just so alone.
Okay, so being alone. Anything
It's just
else?
all of it combined.
It's, yeah, and of course you can't really take them in isolation, right? They all kind of build up, right? They add to each other. So having stated that, but what are your reasons for living? In other words, if you could, if these things weren't bothering you, what would you be doing in life? What do you care about in life? What's important to you?
Well, I really want to someday meet that person and have a family and all those things, but I just can't seem to have time to meet people.
Okay. So meeting people, having a family, those are two different things. One is sort of
Yeah.
like a social, and the other is really kind of settling down.
Or just being loved.
Feeling loved, maybe not feeling so alone or lonely, right? Anything else that you, reasons for living, other things that you would love to be doing or being or pursuing if these things weren't bogging you down?
Well, I'd really like to continue my snow skiing
Okay, so you love to ski.
career.
Okay. Where's your favorite place to ski?
Colorado at Vail.
Oh, wonderful. So as we think about that, Jenny, some reasons for living, some reasons for dying, if I could share a tool with you that has been shown to reduce suicide attempts by 76%, is that something that you'd want to talk about? Is that something that might give you more hope, that you'd be willing to discuss and kind of, so let me stop there. Is that something you'd be willing to discuss?
Yeah.
Okay. And would you be willing to continue to talk with me and try to, we do know that we can help people with these struggles. It's not that we can give you a new job like that, but rather we can help support you in pursuing your reasons to live and managing these thoughts that, as you said, can make you feel out of control. Is that something you'd be willing to do, is follow up with us for some treatment on these thoughts and feelings?
Yes.
Okay. Do you feel like you're going to walk out of this office today and kill yourself? Like you don't have any control, that at any moment, if you leave here, you could die?
No, I don't think so. I think.
Okay. Do you feel like,
talking about it?
Okay, great. Thank you. I'm so glad you said that. We're here to help and we'd love to help. Do you feel like you need a hospital where they're watching you 24/7? Do you need that level of care, or do you feel like you could benefit from and stay safe with a level of care that's slightly less intense, like more like this, what we're doing today?
I think this will be fine.
Okay, great.
Yeah, maybe I'll go stay with my friend Sarah.
Okay, great.
Tonight.
All right, time on that. Where are we in our duration, Kim?
I think we're at 15 minutes.
Okay.
Yeah, we only have like a minute and 30 left.
Okay, good.
So
All right. So thanks, Jenny, for that. Let me hit pause and see if there are any questions. I just want to see if there are any questions. That risk assessment went pretty quickly. We were probably done at like the 9-minute mark because Jenny didn't have a lot of history, not a lot of rehearsal, not a lot of preparation.
Probably should have been a little more intense.
No, I think it was great. You know, what I want to make sure we're calling attention to is at the very end there, where I'm asking you, do you feel like you need 24/7 supervision? Do you feel like you need something less intensive? Can I get you to engage in treatment? Is this, we're not committing, we're not doing like a contract for safety or anything like that, but I'm saying, do you want to engage in this treatment? And would you be willing? I also teed up the crisis response plan, which is what we'll learn about on our last webinar. But any questions from other attendees?
I was going to point out, I think you did a great job when Jenny was talking about, well, maybe I'd get out in traffic or in front of a bus or something. And once you kind of investigated that a little bit, you went into asking her specifically about a firearm or other specific ways to manage the potential danger. And so it was really nice, I think a nice demonstration to see someone so open and direct with that versus a lot of times I think we beat around the bush and people are hesitant, but just this direct approach of specifically asking them.
Thank you for that.
Intent, yeah.
Thank you for that. Other comments or questions about how I approach that? I mean, to Kim's point, if you suspect a heart attack, you're not going to hesitate to say, okay, do you feel any pain radiating down your left arm? Does it feel like an elephant standing on your chest? You know those signs, symptoms, and the nuances, and you just go ahead and ask them, right? With a sense of urgency, but of course not a panic, right? Any other questions, comments? Okay, so I have here 6 people. Caitlin, you're good if I split you into the group, right? So we'll do 3. We'll do, I don't think I'm the host. Kim, I don't have to be the host. Can you create 3 rooms and put everyone in 3 rooms except for Jenny, you, and me? 2 people in each room. And the task, I'm sorry, go ahead.
I think, let's see, I've not done that before, so I'm gonna make you the co-host.
Perfect. Let's do it.
Okay.
So the task ahead of us is we're going to do a quick appointment simulation. And so what that means is if you, let's see, if you are put into a group with someone else, what you will do is one of you will pretend to be the patient, the other will pretend to be the provider, and you will practice the skill. We'll get about 15 minutes. After 15 minutes, we'll close down the rooms, and then you can we'll close down the rooms, we'll chat for a minute or 2, just see how it went, and then we'll open them back up, and you can switch roles where the other person can be the provider and the other person can be the patient. Oh, we've just lost 2 people. Imagine that when we start talking about role plays, appointment stipulations, people drop out. Shocker there. No, I'm sure they just had to go. It's okay. Kim, so I'm having trouble seeing the, I'm not even getting the option for a breakout room now, and I'm not sure why. Let me do this. Can you make me the host? Maybe it'll appear if I'm the host.
Sure.
Let's see if that, okay, now it's there. Nope, no, it's not. No, it's not. Let me see, hold on.
And I made you the host.
All right, let me. I'm gonna close this window and I'm going to see. That's so strange, it's not there. Well, in the absence of being able to do a breakout, we've got 25 minutes left. So we can either do another one like this and we can make it more complicated. If you wanted to do, if someone's bold enough, brave enough to try it and we can watch and share our thoughts, happy to do that. What would you all prefer? We've got 3 of you left here, or 4 of you left, including Caitlin. How would you, what do you feel like would be the best use of your time? Don't all talk at once.
I think we could do another example, especially since it's recording. We'll use this later on. I don't know if does it record breakout rooms, just for my knowledge.
No, typically
No.
it doesn't.
Okay.
So
Okay.
that may be a better use for longevity for this course material if you're recording.
Yeah.
Okay, so we'll do another demo. Thanks, Harry. You want to do a repeat performance? Sounds great. So who would like to be the patient this time?
I'm happy to do it.
Okay, and so this is your chance to if you want to be a really difficult patient, Caitlin, and give me a real run for my money, really. So again, for those who are just learning this, it's really going to show you how to do motivational interviewing, which is a way to handle patients when they are really struggling with their motivation to change, their motivation to engage in treatment. But we'll also go through this in a way that we're essentially reviewing the slides, right? So let me pull that up and share my screen. You've got the steps again. Let me ask this by a yes, no in the chat box. Yes or no, it was clear which of the steps I was in at each juncture. Yes or no in the chat box. It was pretty clear which steps in the risk assessment that I was doing?
Mhm.
So Caitlin says yes. The other folks in here, was it clear? Jenny says yes. How about others?
Yes.
Okay, Harry, you're a little foggy at first, but it got clearer. Okay, good. So what I'll do this time is I'll call out which skill I'm talking about. So SI versus DI, that's the first skill. The second skill is multiple attempt history and history of behaviors. The third skill is assessing the current suicidal episode. The fourth skill is talking about reasons for living. All right. And then the fifth skill is the crisis response plan, but we'll cover that next time. All right, so Caitlin, you're going to be my patient. Do you want to give me just some sort of a who you're going to be? Are you married, single, old, young, male, female?
We could use what I'm presenting with. I could be 27-year-old married person with no kids.
Okay, 27-year-old married person with no kids. Perfect. Okay, and let's again imagine that you're in primary care and you were there for let's say you've got high blood pressure, even though you're 27, you got some high blood pressure. And let's also say that you've had some just some family problems over the years. Okay, maybe really difficult childhood situations, tough upbringing, maybe some bad luck thrown in there too in terms of life events. Okay.
I gotcha.
Hey, and Kim, you'll keep our time again.
Yep.
All right,
Fif-
Caitlin, go ahead.
15 minutes.
15, yep. And Caitlin, make it hard, but not too hard. We need to get done in 15 minutes, right? So
I
we have
got
time
you.
to discuss. So, hey, Caitlin, thanks for coming in. It seems like, do you have a few minutes to continue the conversation that Dr. Smith just started about kind of what's going on in life right now?
I mean, if we can be quick, I didn't expect to talk about this when I came in.
Absolutely. So, Caitlin, I can talk as fast as you can. If you're up for the challenge, I am. Okay. All right. So Dr. Smith said you might be having thoughts of suicide, killing yourself, ending your life. Could you tell me a little more about those?
I mean, who doesn't have those thoughts? I mean, if you knew what I had to deal with every day, I think it would probably make a lot of sense. You know, I'm in here at the doctor's office and I have high blood pressure and I work a job that I don't like. And my husband's out of work right now. So I'm the only earner and it's extremely stressful.
Yeah. So is that kind of what brought all this on? Is that all the life stress, your husband losing his job, or have you been having these thoughts for months and months and months?
Oh no, they've been around for a while.
Okay.
Because I've been stressed. I mean, my upbringing was not easy. So this isn't the first time I've dealt with stress. I feel like I've dealt with it forever.
Okay. Yeah. Yeah. So it's almost like you're on this trajectory, this path that it's just more of the same, huh?
Hmm.
So let's try to get a little bit specific so I can understand how I can best help you. Are these thoughts of like death and dying and I wish I weren't here, or are they all of that plus I wish I weren't here and maybe I'll do something to make myself be dead?
Well, they started out as if like if I just didn't wake up one morning, I'd be fine with it. It would just be easier that way. But then like in the last 2 or 3 weeks, I've actually like thought about how I could make myself not wake up.
Okay, so we're at skill number 1, just footnote. This is differentiating between SI and DI. Okay, so you said in the last few weeks, you started thinking about how you could do something to make yourself not wake up. Okay, now we're going to shift to skill number 2. Caitlin, have you had a prior suicide attempt in the past?
I mean, I don't know if you would call it that. I mean, I was like a teenager and I took too many Benadryl,
Okay,
but I don't
okay.
know.
Is that the only incident like that?
Yeah.
Okay, so if you can try to go back into your teenage mind, when you took those Benadryl, what was the thought going through your head? Was it sort of like, like what were you hoping was going to happen by taking the Benadryl?
That I wouldn't be sad anymore and I wouldn't be stressed out. So I guess I was hoping that I didn't wake up.
Okay, so you knew that Benadryl at the time was a sort of, it had a sedative or sleepy effect on you, and that was an allergy med, but you were hoping that it would make you fall asleep and not wake up.
Yeah.
Okay, so how many Benadryl did you take?
Like 8.
Okay, so just a footnote here. It doesn't matter how many she took. If her intent at the time was that it would kill her, then it counts as an attempt. Okay, all right, Caitlin, so it sounds like, like you said earlier, a lot of people have stress. It's actually quite common for people to have what we call death thoughts, which are like, I wish I were dead, I wish I weren't here. And then as you've described experiencing yourself, sometimes those grow into sort of like, well, maybe I should be the one to make myself not be here, right? And so you said over the last few weeks, that's what you've been experiencing. You've had one suicide attempt in the past. So let's talk about the current, what's happening right now. So just for the folks at home, this is skill number 3. We're assessing the current suicidal episode. So Kim, Caitlin, excuse me, do you have sort of like, is it happening once a day, once a week? How often are you thinking of killing yourself?
I think about it at least once a day. I mean, there's always something every day that just stresses me out.
So am I right that sort of like when you get stressed, this pops into your head?
Mm-hmm.
Okay. And how long does it stay in your head? For like 5 minutes, 10 minutes, an hour?
Like probably an hour until I get busy doing something else.
Okay. Okay. And so is it that someone else has to distract you and kind of pull you back to where we are? Or do you have sort of the power to switch it off and focus on something else?
I think it depends on the day. Some days I'm able to do it myself, and then some other days I have to like talk to my husband or I have to call my friend or something.
Okay. And are they always work stressors?
No, I have a difficult relationship with my mother, and when she calls me, it's really loud when that happens.
Okay, that's really helpful to understand, because I'm betting, and you help me understand this, tell me if I'm wrong or right, that some of what comes up for you when she calls you just brings up a whole lot of stuff from childhood, from that difficult upbringing you mentioned.
Exactly. That's it.
Yeah.
So she's never apologized. We never talked about it. So it just stays there.
And so it's like, not only are you living with a lack of closure, but it sounds like just the muck is stirred up every time she calls.
Yeah.
It just like brings back all this old stuff, right? And this intense stuff. And because you haven't had closure to it, it's still intense, it's still raw. Am I understanding you?
Yeah.
Okay. Okay. Have you let's talk a little more detailed about how you might do it. Have you planned, rehearsed, thought of any ways you might end your life?
Well, I mean, if I tell you that, are you going to throw me in the hospital?
No, what I can say is that the best use for the hospital is to keep you on 24/7 supervision to prevent you from killing yourself. So generally, I use the hospital when patients say, you know what, doc, I'm not going to be able to control myself. I'm not going to be able to focus on anything we talk about together. I'm way too worked up, and what I need is to just have a place where I'm totally safe and someone can protect me from myself. So that's when I typically hospitalize people. Caitlin, is that where you feel like you are today?
Not today.
Okay. Have you ever been in that place? Other than when you were a teenager and took 8-Benadryl?
No, I haven't got that far yet.
Okay. So if you haven't gotten that far, that's actually a good indicator. Why do you think I'm saying that's a good indicator?
Probably because it hasn't progressed that far.
Correct. That's exactly right. Yeah. So there's something you're doing, whether you realize it or not, Kim. There's Caitlin. I keep calling you Kim. There's something. It's because in the screen she's right above you. So Caitlin, there's something you're doing that is helping you cope more effectively than perhaps when you were a teenager. And so you may not realize it, but want to make sure that you're crystal clear that there's really no one to give credit except you. That there's something you're doing that's managing it. Are you aware of what that is?
I don't know. I'd probably spend more time talking about it, but I appreciate you saying that. It makes me feel like I do have some control over this.
Well, you do, or you'd be dead. Quite honestly. And I don't say that, that's not a joke. It's when people are really, really out of control, things happen, whether they get arrested or whether, what, I mean, has anything like that happened to you?
Mm-mm.
No. Okay. So let's move on now. For everyone who's learning, we're now moving on to skill 4, which is hitting on the ambivalence and the reasons for living. So Caitlin, is it okay if I share with you kind of what the medical field has taught us about suicide and kind of what's going on in people's minds when that happens?
Sure.
Okay. So suicide is a state of ambivalence. It means we have reasons for living and reasons for dying. And most people who are suicidal don't actually want to die. They just don't want to live with all their stuff. Does that describe you?
Yeah, if I didn't have all this stuff on me, I'd be fine.
Yeah, that makes total sense. I mean, so you have mixed feelings, you're ambivalent, because to be honest, Caitlin, the people who are not ambivalent, they're already dead. They kill themselves quite quickly, right? So the fact that you're still living, breathing since that teenage attempt, the fact that you came in for help today, it's sort of evidence that you don't just want to die, that you also want to live. Otherwise, why would someone seek help, right?
Yeah.
Yeah. So would it be okay if you mentioned that your reasons for dying, can we talk a little more about this? Is that okay if we delve in like one layer deeper?
Sure. Yeah.
So you talked about your reasons for dying a few minutes ago, and you said like your husband's lost his job, you're the sole breadwinner, you've got some stuff left over from childhood, really tough childhood, that it gets stirred up every time your mom calls. Any other reasons for dying or things that are related to wanting to end your life?
No, I think all roads lead back to the things you mentioned.
Okay.
It's like kind of smaller stuff, but it all goes back to that.
Okay. And then if we sort of remember that ambivalence, we have reasons for living, reasons for dying. What are your reasons for living? Like why are you still alive today? What would you be doing if you didn't have to grapple with all these reasons for dying?
I mean, I really like my husband, so I'm around for him because I don't want to cause him pain. I do animal rescue, so I'm really into that, and I think I would do that a lot more if I didn't have all this stress on me. I find that's a good outlet. I would travel. I would see my friends more. It just feels like this is a big obstacle to me being able to do what I want.
Yeah. Yeah, that's what most people say. It's like all those things they love, they're not even able to do them. So life's not worth living, right? Is that kind of how it feels?
Exactly.
Okay. So if I could give you a tool that would help increase your chances, or let me say that differently. If I could give you a tool that research has shown decreases suicide attempts up to 76%, is that a tool that you want me to share with you today?
Yeah, anything will help.
Okay. And do you feel like this level of care is going to help you right now, or do you feel like you need a higher level of care, like maybe going to the hospital where they're kind of 24/7 because you can't keep yourself safe? What do you think you need?
I think I'm safe today, but can I call and talk to you if I get to that point?
Oh, absolutely. We'll go over that's part of that tool I mentioned. It's called a crisis response plan. And we'll go over all the steps of exactly what you can do to help yourself in that moment so that you feel empowered, you feel equipped, you feel like armed with a handful of tools to manage this sort of intolerable stuff. Okay, time. Where are we, Kim?
2 minutes and 45 seconds.
Oh, good. I timed poorly because I thought I was at like the 11-minute mark, but still, questions about that, reflections about that. How did that sound?
I'll say it's weird to be on the other side of it. But I mean, it's not weird. It's like, it's good for me to be able to see what they're experiencing when I'm talking to them. Yeah.
Yeah. What was that experience like? I mean, did it feel rushed? Did it feel insensitive? Do you feel like I was overpowering you? Was I too heavy-handed? What did it feel? Did it feel empowering?
No, it felt the confidence that you had. You gave it to me. So I didn't feel confident talking about it. I didn't feel confident in my ability to deal with it. But your confidence in the tool, your confidence in the research and how you presented it, I think that transferred really easily.
Okay. So my ease with talking about it, just matter of fact, how about this? How about that? Does it work like this? Could I share with you what the medical research says about that? That felt like it made you more confident, more comfortable, more willing to engage.
Yeah.
Okay. Great. Thanks for that. Okay, there's a comment in the chat box, very helpful. Thanks. You're welcome. Any other comments? Harry, you said the first time was a little foggy, but it got clearer. Was this one clearer? Or maybe just seeing a second one in a row, the method became clear or the sequence became clear? Okay, so seeing it twice helped. That's great. Fantastic. Or hearing it, yeah. Yeah, at the end of the day, notice that I didn't get caught up in all of the psychosocial circumstances happening in either case. I didn't, other than asking what was going on when these began, what changed in life, other than understanding sort of whatever the trigger was or the precipitating stressor, I didn't go into any of that. And that is something that oftentimes physicians, nurses, social workers, psychologists, it's kind of a landmine that we step in, or a bear trap we step in. That's probably a better one, because we step in the bear trap and we're immobilized and we just get stuck in this place talking about all the things that are going on. And then it seems to be like, okay, well, what are we doing? Where do we go from here? And so just want to both demonstrate that and encourage you to not feel compelled to go into all that background stuff. It doesn't help us better determine what the patient needs. Also want to sort of point out the idea that I am quite transparently sharing with her, this is the purpose of the hospital. Do you feel like you need this? And then trusting her opinion. She knows herself best, right? Now, if you're a little nervous about your license and you want to say, well, then ask her, has she ever had a history of losing control? And that those histories of predictors are fair predictors for the future. In fact, of all the risk factors we know, the most robust risk factor is a history of behaviors. It's the old saying that what people are currently doing or what they were historically doing is the best predictor of what they'll do in the future.
So would you say that it's, I don't want to say assume, that's the wrong word, you don't just assume here, but so since I said something about using pills with my first attempt, is that something we would consider as a
lethal means?
Yes, that's what I'm trying to say.
Yes and no. Yes and no. What I would have asked, could have asked, is, so Caitlin, when you took those 8 Benadryl, did you end up in the hospital, or did you just kind of wake up the next day?
Mm-hmm.
What happened, Caitlin?
Oh, I woke up the next day.
Okay. And when you woke up and you realized that you were not dead and you were alive, what was your immediate thought and feeling? Was it sort of like, oh God, thank goodness I'm alive, I have another chance? Or was like, oh man, I wish I were still dead. I can't believe I screwed that up. I should be dead.
I mean, it was relief. It was
Relief.
relief.
Okay. So just for the group, that's the post-attempt response or the post-survival response. So it is a good indicator of what's to come. It's not surprising that even though this was a fictitious case, that Caitlin attempted it at teenage years and has not attempted since. That is consistent with that post-survival response of relief. And again, that's what the majority of people will experience when they survive an attempt, is they will feel relief and like, I'm not trying that again.
I will say, I mean, every single part of this process is important, but for those watching now and those watching in the future, I use that every time I talk to someone. So like when I'm going through this framework or this workflow, and do you have a previous attempt? What did you feel after you woke up after that attempt? And it helps guide me, right, to helping them the best way that I can. So super important.
That's great feedback, Caitlin. Thanks. All right, I'm seeing about 5 minutes left, so I'm going to shut my trap and ask if there are questions or comments.
I just want to say you both did a fantastic job role-playing. Thank you.
You're welcome. And thank you guys for having us. And thanks everyone who attended. Appreciate you. Next time, let me switch back to my slides. I think I might have 1 or 2 final slides. So next time what we'll talk about is the crisis response plan, which is that tool that can decrease suicide attempts by up to 76%. Here is another version of that flow chart. Again, everybody learns differently. So some people prefer visuals and flow charts. Some people are much more checkboxy or list people. So here's another way to look at these skills. All right. And this bottom one here will transition to a CRP, not simply a safety plan and never a safety contract. We'll touch on that next time. Here are those 3 books I'd encourage you to take a look at. Here's a bunch of resources. And again, as always, if you have any questions or want to shoot me an email, feel free if you have a case you want to bounce off, kick around, happy to discuss. So thanks again, and I'll see you next week.
Thank you, Dr. Corso. Thank you, everyone. Have a great week.
Bye.
Bye.